ti dufa ti swat with put a tish poyalapaj a slot still alti disha to all turi tuha.
This is the land right here that the Puyallup people have lived on since the beginning.
Desha ti dufa chas alti swat with put.
This right here is where we are in the world, our homelands.
Uyayus chas ati swatufta a tish tu ishachas. Ukacha chas tish badadat chas. Uoch twati halal ati swatufta a tish Puyallup.
We work on our ancestral lands. We raise our children who go to school on the land of the Puyallup people.
Oheg wed chas ti shwananam tliti ohashitep ti pasted okwaredu.
We acknowledge that the Medicine Creek Treaty was signed for the whites to take our land for their benefit.
Ochoshituk chas a ti shunanam tliti a ti swatwif put chas. Otuk ti pasted squat lup swatwif put lup. Toch al bequechitub a ti pasted ti swatwif put.
Land was assigned to our people. The Caucasians said, "This is your land," and they took that land from us too.
Okararitub chas ati swat with put chas. Odzak atub ti tliti.
Our land was stolen from us. Treaties were broken.
Toch didi chas tislachel.
But we are still here today.
Uhuihui chata ukweli chata ish.
Our people forage for food and materials, we pick berries, we canoe, we practice our traditional ways, and we speak Twelshutsi.
Just as our ancestors did.
Hoya chas.
We are finished.
All right, thank you for everyone for taking a moment to join me with that acknowledgement. And if Carolyn is ready to go, I'm going to turn this over to you. And whenever you're ready to advance the slide, you just let me know and I'll do that for you from my end.
Awesome, thank you.
Thank you. Welcome, Carolyn. We appreciate you joining us today.
Yeah. Hi, everyone. And thank you to Kendra for the introduction and for operating the slides today. My name is Caroline Blackburn, and I am a recent graduate of the University of Puget Sound's brand new Masters of Public Health program. This past semester, I had the privilege of working with both the Tacoma-Pierce County Health Department and the Perinatal Collaborative of Pierce County in completing a literature review examining the known causes of delayed and eliminated prenatal care, with a focus on factors affecting people living in Pierce County. Today, I'll be presenting the results of that research to you, as well as some next steps that providers can take to improve prenatal care access. Next slide, please. So a quick note on terminology before we begin. Prenatal care is a highly gendered topic, and the majority of papers I read for this project use gendered terms such as pregnant women, maternal health, and mothers. However, not all women can become pregnant, and not all people who can become pregnant are women. Throughout this presentation, I'll be using both gendered terms and gender-neutral terminology, such as pregnant people, survey respondents, and veterans. I will also be using both person-first language, for example, people with disabilities, and identity-first language, for example, disabled people, as opinions on what terminology is preferred vary. I'd also like to emphasize that I was completing this project over the course of a semester, which is an abbreviated timeline for a systematic literature review, and the topic of prenatal care access is very broad. I also only have 40 minutes to present to you all today, so I think I've managed to fit everything in, but this is definitely an overview of a very broad topic, and there's a lot more information available in scientific literature. In addition, because this project was focused on modifiable factors, my advisors at TPCHD and I chose to exclude research that looked solely at the impact of Medicaid expansion on prenatal care access due to the perceived lack of modifiability in that factor. Next slide, please. So why prenatal care access? Prenatal care, or PNC, is an important component in reducing the risk of preterm birth, as well as reducing the rates of infant and maternal morbidity and mortality. Adequate or good prenatal care has two main components: the timing of initiation, ideally in the first trimester, and the total number of appointments a pregnant person receives. One of the most common ways of measuring prenatal care adequacy is with the Kotelchuk index, which is calculated based on when prenatal care was initiated and the number of prenatal care visits adjusted for the gestational age at birth. It categorizes prenatal care as no care, inadequate, intermediate, adequate, and adequate plus care. The quality of care received is also an important component of prenatal care adequacy, but this is very difficult to measure and is generally not included in adequacy analyses. As of 2021, 75.6% of American women receive early and adequate prenatal care, which is below the national target of 80.5% of women. Because this 76.5% is a national average, the real proportion of pregnant people receiving early and adequate prenatal care varies across regions and demographics. Next slide, please. Prenatal care adequacy is a health concern in Pierce County specifically, as you can see from this map. This was provided to me by Ingrid Freiberg at Tacoma Pierce County Health Department and shows the proportion of women who initiated prenatal care late after the first trimester in Pierce County from 2016 to 2020. In some areas, 35% or more of women initiate prenatal care late, and even those in areas with 20 to 25% have a higher proportion of women with late initiation than we would like to see. A recent community health needs assessment conducted by Marybridge Children's and TPCHD showed that 30.4% of mothers in Pierce County do not receive adequate prenatal care, which means that the proportion who do receive adequate care is just below 70%, and this is actually lower than the national average. Researching the reasons why people don't receive adequate prenatal care was decided as the first step in fixing this problem, which is how I came to work on this project. Next slide, please. For this systematic literature review, I originally searched the databases PubMed, PsycInfo, and Cochrane Library for qualitative and quantitative empirical research, as well as other systematic reviews published in the past 15 years that focused on barriers affecting prenatal care access and utilization. My initial search results yielded 3,722 article titles, which was narrowed down to 450 abstracts after title review and duplicate removal. At this point, my advisors and I began several rounds of review, which included the decision to change the inclusion criteria to only include research from the previous 5 years, since over half the articles were published in that time period. At the end of this process, I was left with a total of 52 articles to include in the systematic review. Next slide, please. One of the most common data sources used across research articles was the Pregnancy Risk Assessment Monitoring System, also known as PRAMS, which is the United States national level surveillance system for pregnancy and maternal health outcomes. This data can be limited because it only allows for quantitative responses, and only 60% of people invited to respond to the survey actually fill it out. However, it does ask respondents if they experience barriers to receiving care. If a respondent says, "No, I could not get an appointment as early as I wanted," she then has the option of selecting up to 11 barriers that affected her ability to obtain an appointment when she wanted. Across studies, some of the most commonly reported barriers are not having transportation, not having childcare, not being able to afford care or not having adequate insurance, having difficulty obtaining an appointment, and being too busy. The frequency with which these barriers are reported varies across groups. For example, primiparous women aren't very likely to cite childcare as a barrier, and in one analysis, American Indian respondents were less likely than non-Hispanic white to report having problems with insurance. Some groups, such as people experiencing domestic abuse or those affected by incarceration, are more likely to report keeping the pregnancy a secret as a barrier to care. However, the 5 barriers I have listed on this slide were the ones that I saw reported most frequently across studies. Next slide, please. Also across studies, one of the most frequent themes I saw was the role that fear, stigma, and discrimination play in accessing prenatal care. Some women are afraid of what being pregnant means for their lives and their health and avoid going to PNC because they are in denial of what their pregnancy means for their life. Some don't know what a prenatal care appointment entails or why it's necessary and avoid care for that reason. Others may fear or experience poor treatment from providers, whether because they're homeless, they're on Medicaid, or any of a number of other reasons. Some pregnant people are substance users who are afraid of presenting at prenatal care while using and having their children taken from them. Some pregnant people also experience outright discrimination from providers, whether because the provider refuses to initiate care or because quality care is denied to the patient once they're in the office. In one study, in which a researcher called providers to ask if they would take a hypothetical patient, 66% of them declined to see the patient when she was a refugee, and half of those providers did not share a reason why they refused. In another study, a Spanish-speaking woman shared that a nurse refused to give her an injection to prevent preterm birth because she was undocumented and lacked insurance, although she was able to pay out of pocket. If none of the barriers I talked about on the previous slide existed, if transportation wasn't a problem, or if every doctor's office had a daycare attached, or if no one had to worry about affording care, then fear, stigma, and discrimination would still prevent women from seeking and receiving prenatal care. Over the next several slides, I'll be discussing more specific group-level inequities and disparities. While I talk about those, I would appreciate if you would keep this aspect of the problem in mind, as it is one that affects all pregnant people in different ways. Next slide, please. So, racial and ethnic disparities. I'm not going to go into too much depth on this topic, because while it is an important one, it is also more frequently studied and reported on than some of the disparities I'll be talking about next. Among the literature examining racial and ethnic disparities, the most frequently reported on groups were Black and African American individuals, as well as Hispanic and Latina. Across studies, Black individuals had worse prenatal care outcomes than non-Hispanic white individuals, including a decreased likelihood of receiving adequate care, and an increased likelihood of initiating care late, and experiencing more barriers to care. Hispanic and Latino individuals had somewhat better but still moderate prenatal care outcomes compared to non-Hispanic individuals, but are affected by anti-immigration rhetoric and may have been less likely to seek prenatal care at the height of the COVID-19 pandemic. American Indian and Alaska Native individuals also experience worse prenatal care outcomes than non-Hispanic white individuals and have more concerns than other racial groups about being able to access culturally appropriate care. Research suggests that a lack of insurance may not be a barrier for this population. However, being able to afford care and needing transportation to appointments may still be problematic. Other ethnic groups are underrepresented both in this review and in research on prenatal care outcomes in general. One study examined prenatal care outcomes for Arab American mothers compared to... Sorry, can we go back a few slides? Or forward? Yes, thank you. This is the correct one. So one study examined prenatal care outcomes for Arab American mothers compared to non-Hispanic white, and found that Arab American mothers had greater odds of not initiating prenatal care in the first trimester. Some studies reported results related to people who identified themselves as Asian, who may be at increased odds of experiencing keeping the pregnancy secret as a barrier, but also may not differ from non-Hispanic white individuals in their ability to obtain prenatal care when they want it. One problem with population-level racial and ethnic data in the United States is that the category Asian generally groups people from East Asia, the Indian subcontinent, and the Pacific Islands together, which may mask disparities between groups, especially for Pacific Islanders. One study included in this review focused on U.S. Marshallese women living in Arkansas, and many of the women they spoke to reported experiencing barriers resulting from a lack of health literacy. Many of them did not know what prenatal care was or why it was important, and also from a significant language barrier between themselves and providers, who are often unable to provide translators who spoke Marshallese. This is an example of the type of disparity that is masked when one groups Asian Americans and Pacific Islanders together, and shows the importance of research with Pacific Islander individuals in communities where they make up a significant part of the population. Next slide, please. Thank you. Over the next few slides, I'll be sharing data and results related to other group level disparities, including individuals with disabilities, veterans, those who are far from their providers, people experiencing incarceration, and substance use. Next slide, please. Prenatal care outcomes for disabled people frequently vary by type of disability, but overall, compared to able people, people with disabilities are overrepresented at both ends of the adequacy spectrum. They're at an increased likelihood of not having adequate care and of having adequate plus care or more than the recommended number of appointments. As far as variations by type of disability go, people with physical disabilities such as musculoskeletal disorders, congenital anomalies, or permanent injuries tend to have the best outcomes overall and may be more likely to enter prenatal care in the first trimester compared to abled women. Individuals with sensory disabilities may be more likely than abled women to have inadequate care, but higher proportions of vision-impaired individuals compared to non-vision impaired initiate prenatal care in the first trimester. On the other hand, the proportion of individuals with hearing differences who initiate prenatal care in the first trimester is actually lower than that of people without hearing differences, which is another example of how grouping categories together may mask disparities. Individuals with intellectual and developmental disabilities tend to fall into the extremes of prenatal care outcomes, where they're at significantly increased odds of not receiving any care and of receiving intensive care compared to abled individuals. And all of this data comes from quantitative population level studies, so there's limited information available on how and why disability affects prenatal care outcomes. All we know from this information is that it does. Next slide, please. Veterans and active duty U.S. military members are a unique population in the United States, in large part because this group has near universal healthcare access and insurance, as well as unique health needs. In one study, veterans who used Veterans Affairs benefits to access maternity care compared to non-veterans and veterans not using VA benefits received their initial appointment latest out of all groups. However, veterans using VA benefits were the most likely to receive adequate care, which suggests that the problem is in care access for this group is with bureaucracy and not the care itself. There are also racial disparities present in prenatal care outcomes for active duty service members. Black, American Indian, and Asian Pacific Islander service members are all at an increased risk of initiating prenatal care after the first trimester compared to non-Hispanic white service members. This is especially notable considering the supposed universality of healthcare access for service members and suggests that other factors may be at play. There are also other factors that specifically affect prenatal care outcomes for service members. Having a current PTSD diagnosis may increase one's likelihood of receiving early and adequate prenatal care, serving as a protective factor for service members. However, having depression and having experienced rape during one's time in the military may negatively impact a pregnant service member's ability to receive prenatal care as early as she would like. Next slide, please. So, as I mentioned earlier, almost all analyses of PRAMS data will reflect transportation as a barrier to prenatal care. However, it is difficult to tell from that data exactly how and why transportation is a problem. There is evidence to suggest that rurality in and of itself is not enough to significantly affect prenatal care outcomes. Instead, among both rural and urban individuals, how far one is from the provider has a greater impact on outcomes. Living 20 or more miles from a care provider is associated with receiving fewer second trimester appointments compared to living 19 or fewer miles. And women who don't receive any prenatal care may be more likely to rely on public transit and also have longer routes to healthcare centers and have more stops along those routes than women who do receive prenatal care. Patients with longer commutes may also be more likely to arrive late or cancel appointments compared to those with shorter commutes. In that study, each 10-minute increase in travel time was associated with a slight increase in one's odds of canceling the appointment or arriving late. These 10-minute increments may not seem like a lot, but in that study, the median travel time for patients was 48 minutes. Those 10-minute increments add up quickly and can significantly impact one's ability to get to their appointment on time. So what that means is that if a pregnant person lives further from their provider and has a longer commute or needs to take public transit and has more stops along their route, chances are they'll have fewer appointments and then potentially poorer attendance at the appointments they do have. Next slide, please. Being exposed to incarceration also affects prenatal care outcomes. And incarceration exposure is a term taken from analyses of PRAM's data, and it is defined as either the survey respondent or their partner or spouse experiencing incarceration at any point in the year prior to the respondent giving birth. And this data does not differentiate between whether the respondent themselves or their spouse were the ones incarcerated, which is somewhat unhelpful in trying to determine how being incarcerated affects prenatal care outcomes. However, from PRAMS, we do know that respondents exposed to incarceration experience more barriers to care than those not affected by incarceration. And those who had been exposed to incarceration were younger, more likely to be Black or Hispanic, and less likely to be college graduates. The National Commission on Correctional Healthcare and the American College of Obstetricians and Gynecologists have established standards for pregnancy-related healthcare in correctional facilities in the United States, and those standards include access to regular prenatal care. Canada does not have those standards, and in one study of Ontario women, both those who had been incarcerated during their pregnancy and who had been incarcerated at any point during their lives had worse prenatal care outcomes than women who were never incarcerated. Again, there are no standards for pregnancy care for incarcerated women in Canada, while there are in the United States. However, the populations more likely to be exposed to incarceration in the US are also those who are already at increased likelihood of having poor prenatal care outcomes. In addition, the existence of standards for care is not a guarantee that those standards are being met. Therefore, this may be an area of higher concern than the data currently reflects. Next slide, please. For this presentation, I'll be focusing on illicit substance use, although non-illicit substances like alcohol and tobacco may also affect prenatal care and infant health outcomes. PRAMS respondents who use substances such as cocaine, heroin, amphetamines, and/or marijuana have 70% increased odds of receiving inadequate prenatal care compared to people who do not use substances. If marijuana use is removed from this analysis, as its legality varies across the United States, then the odds of receiving inadequate prenatal care for substance users jump to 270%. These odds are even worse for BIPOC individuals, especially American individuals and American Indian and Hispanic substance users. However, there is research to show that women who have been diagnosed with and treated for a substance use disorder and who are no longer using substances have identical prenatal care outcomes to women who've never used illicit substances. There are state-level policies governing prenatal substance use strongly impact prenatal care outcomes for substance users as well. While not all states have substance use policies, governing prenatal substance use, the two categories of policies that states generally do have are punitive and priority treatment. Punitive policies criminalize prenatal substance use, and women in states with that type of policy are less likely to receive prenatal care and have worse outcomes when they do than women in states without punitive policies. In comparison, priority treatment policies work to get pregnant substance users treatment early, as well as provide other social support and health services, and work to prevent discrimination. The presence of priority treatment policies increase prenatal care utilization for all women, and the Washington State Department of Health has a program that certifies hospitals as centers of excellence for perinatal substance use, which is a promising step in the right direction. Next slide, please. So the key takeaway from this presentation is that there are multiple factors that can affect a pregnant woman's ability to receive early and adequate prenatal care, whether because she faces barriers to care, discrimination, or is a member of a group affected by health disparities and inequities. As I mentioned at the start of this presentation, This is a very broad overview of this topic, and there's a significant amount of room for additional research. This includes more specific systematic reviews, as well as analyses of PRAMS data from Pierce County, and additional qualitative research to learn how specific communities are impacted by different factors. Next slide, please. There are also, thank you. There are also several steps that can be taken at the clinic level to improve access to early and adequate prenatal care. One of these is considering transportation and population needs, especially when planning where clinics are located. Proximity to childcare, having alternative hours and scheduling options, and being near a transit line that runs frequently and consistently are all key in reducing barriers related to scheduling, childcare, and transportation. Considering your population's level of health literacy and language needs is also important, as is being aware and appreciative of cultural differences. Eliminating implicit and explicit discrimination and bias is also extremely important among both providers and support staff. Other actions that can be taken include linking prenatal care to other support services, such as those for incarceration-exposed individuals, veterans, and queer and BIPOC individuals. Pregnancy can be an isolating experience, and having access to additional support also promotes well-being during pregnancy. Being able to link pregnant patients to WIC services, food banks, and other resources and benefits helps promote well-being both during pregnancy and after giving birth. Next slide, please. Thank you so much for your time and attention today. Does anyone have any questions?
Thank you so much, Caroline, for that wonderful presentation. You've definitely put a ton of work into this literature review. You are getting some congratulations and thank yous in the chat. I don't have any questions coming up in the chat quite yet, but if anybody has any questions, thoughts, or comments, please feel free to unmute yourself or put that in the chat. Again, I'm getting a lot more thank you. Great presentation. Great job, Caroline.
Just real quick, this is Johanna Wolf, and I worked with Caroline, and she did a fabulous job presenting this, and it was certainly something that we thought was important to address because of the high rate of inadequate prenatal care within Pierce County. So just want to challenge everyone, especially people who are providers on the call, to think about, to take with you some of these suggestions and definitely this information, and think about ways in which you can maybe address one or two of these suggestions and improve things within even your own sphere. So that would be my hope, and we are definitely going to continue this work and keep you all posted. So thank you so much.
This is Kendra again, and just for the sake of discussion for the group, I'm curious for those of you that are prenatal care providers or working with mothers during that time, if you are hearing any alignment from your clients on what their barriers to care are with what Caroline was finding during her literature review. Or just what are we hearing from clients here in Pierce County? Anybody have any thoughts or input on that? And yes, Rebecca, this presentation will be available on our website. We'll have all of the slides posted there. Thank you for asking. Okay. Well, thank you again, Caroline. We really appreciate your time today. Thank you for all of your hard work on this really important subject. Our next presenter is Kate Cranfield, but I think there is a possibility that she may not quite be on with us yet. Kate, are you on with us already? Looking through the list here. I don't think so. So we will just go ahead and jump forward to some of our committee updates. Let me get us to that slide. I'm just going to toggle through here quickly. All right, we'll just be taking a few minutes per committee to let you know what we have going on with our different PCPC committees. And as always, we encourage anyone that is interested in participating in any of these to reach out to the coordinator for that committee. Erin, are you on and available to present right now?
I am. Hi there, everybody.
You.
For those I haven't met, my name is Erin Suma. I work for Marybridge Children's Hospital in the Center for Childhood Safety, and I'm representing our Safe Sleep Cribs Committee today and on our PCPC board. So a little bit of background, if you don't know about us, I know a lot of you partner with us and know kind of what we do, but we just last year hit 10 years of this Safe Sleep Cribs Committee because in late 2012, the PCPC was given 2 $1,000 grants to start a cribs program. We had no program, no staff, no paperwork, no process, no training, no cribs. So that's what kind of started it all. And in that first year, we developed the entire program. We recruited 11 different agencies from within the PCPC who wanted to be able to give out free portable cribs to their clients. And trained 50 staff members that first year. And our very first crib was distributed at the end of July 2013. So we are rapidly approaching our official 10 years from our first crib distribution anniversary, which is really exciting. Some of us on the committee have been here since the beginning, like myself and Aileen Carroll. So in the last 10 years, we have managed to raise over $100,000 and distribute just under 1,200 cribs through 24 different PCPC partner agencies. We do provide an annual training to any of the staff who participate and give out our cribs are trained every year, so we keep everybody up to date. So they're educating families correctly on safe sleep and SIDS-SUID prevention. And at this point, we're training about 60 people a year because new people are coming in, some people are moving out, and everyone's kind of getting their annual updates. That's been kind of our average since we started the annual trainings. I do want to note that this program has no designated staff, no designated funding. It's just a subcommittee of this group who cares deeply about this subject matter and gets together to raise money and train staff and get the cribs and store the cribs, and all of the different parts and pieces of running this program are just kind of donated through our committee members' time. That said, we are always welcome to more help to pull all of that off. We meet on the second Tuesday of every month, so that should be tomorrow from 1:30 to 2:30, and we've been doing it virtually since COVID, and I don't have any current plans to change that. But you are welcome to become a part of this committee, particularly if you are someone or your agency is a partner and using our cribs. We certainly would love your assistance to help us pull that off. So please feel free to reach out to me. My email there is down at the bottom. It's just my name, erin.suma@multicare.org. That's also on the PCPC website. So if you want more information about the committee or about our work or about joining, becoming a partner, if you're not one already, please reach out. Kendra, can you go to the next slide? I have one more. That's just a little bit of a why we get together and do this. And all my crib partners who get trained regularly know this by now, but it's because sudden unexpected infant death, or what's called SUID, which includes both SIDS and unintentional suffocations in the sleep environment. This is the leading cause of death for infants between 1 and 12 months of age. So we see this more than anything else. According to all of the major medical and health related groups in the nation, the American Academy of Pediatrics, the National Institutes of Health, the Centers for Disease Control, and others, the primary prevention strategy that we can use on kind of at a community-based level is to provide and teach on safe sleep environments for babies. And so that safe sleep environment is a crib, a bassinet, or pack and play that meets current federal safety standards. And so the one that we distribute is a portable crib, kind of like a pack and play, called the Cribette, and it actually has little safety messages actually built right into the product, which we like. Inclined sleepers, anything that elevates babies' heads, baby boxes, various types of things that look like they're for sleep but don't necessarily meet federal safety standards are a no and should not be distributed at this time. We do find we do this work because a lot of families want to provide their baby a safe sleep environment and can't afford to. So that is where we can step in and provide that for them. We do find when we survey our partners and our recipients, 80 to 90% of the people who get one of our free cribs report that they would have brought baby into bed with them if they had not gotten the crib and education from us. And we know that bed sharing significantly increases the risk of death for infants. So that's a good thing. We're getting cribs in the hands of people who really were not in a position to be able to have their child sleep safely. So if you want to help, if you're interested in this work in the way that we are, there's a number of ways. Only one of them is joining our committee. Also educating yourself and your families on safe sleep practices, keeping yourself up to date on those things is really helpful. I mentioned our crib training a few times, and the next one is tomorrow. So for those of you that are due or interested, we do have another training tomorrow. If you're having trouble, someone is saying something about sold out. It's not a sold thing, but if they're no longer accepting new registrations today, she's that's about 24 hours before. So I would think you'd still be able to get in, but if you can't, email me and I'll connect you with the with Liz over at NISA, who handles that registration. So I will also pop the link to register in the chat. It shouldn't be sold out. I don't think it has a limit on the number of people, but Alicia, since you're telling me that, I'll forward that information on to Liz to make sure that it's set up. So that's all I have. Unless anyone has any questions, I will pass it back to you, Kendra, and I will put the link in the chat. So let's see if that'll work.
That's so great. Thank you so much, Erin. We appreciate all that information and hoping that you get quite a few takers on your safe sleep training tomorrow. I also see that Kate Cranfield has joined us. So we are going to go ahead and hop backward through these slides and we will let Kate take over. Sorry, I realize it's probably not the most efficient way to do this, but I am limited on screen capacity here. Okay. Kate, are you ready to jump in?
Yeah, can you hear me okay?
Yes, we can hear
Great.
you. Thank you so much for being here. We're excited to have you.
Yeah, thanks so much for having me. My name is Kate Cranfield. I am a nurse at Tacoma Pierce County Health Department. I work in our communicable disease control program, and I work on a variety of immunization promotion activities as well as in school health. So really happy to be here sharing some information on vaccines in pregnancy and early childhood. Next slide, please. All right, so I just wanted to start off with some basics that, vaccines, do protect during pregnancy. What's really great about vaccines is they actually protect the pregnant person, the mom or the mom and the baby. And many vaccines are safe to receive during pregnancy and offer benefits such as reduced risk from disease complications. And then, like I mentioned, pass on that passive immunity to the baby when they are born. On the next slide, I think that I have a link to a handout about which vaccines can be given during pregnancy, should be given during pregnancy, and if it's okay that they're given during pregnancy. Because as we know, there are a number of different vaccines, and they or some of them are made, differently, such as our live virus vaccines, which are MMR and varicella and the nasal spray flu, and those should be avoided during pregnancy. So I do think that vaccines are, an important part of prenatal care that should be addressed with patients. Next slide, please. So I just wanted to go over some of the recommended vaccines during pregnancy. So the first one that we really think of, is Tdap, of course, and that's given between 27 and 36 weeks gestation. And the real key piece here is it's protecting that newborn from pertussis. So when they're born, it's too early for them to get, their own DTaP vaccine to protect them from pertussis or whooping cough. And that can be, a really scary disease for newborns. I don't know if any providers have seen a newborn with pertussis or, any videos of them, but it is, really scary. Anything with babies and, compromising their breathing. So Tdap is given every pregnancy. Normally, if you're not pregnant, it would be, you get that Tdap in every 10 years, but no matter what, we want that given during pregnancy and every pregnancy. And then the other one that I think of is flu. So the flu vaccine, of course, protects folks from serious complications to flu. And as pregnant people are more susceptible to those complications. It also, works in that passive immunity once again and passes that protection on to the newborn, which is, again, really important with this respiratory virus. As far as when to give it, it is just, given every year. So, part of the annual schedule. And then I mentioned this on the last slide, but use, the injection, which is the inactivated form of the vaccine, and not LAIV is a live attenuated influenza vaccine. So that's the nasal spray. So would want to avoid that and get the shot. The other one that I added on here was COVID-19, obviously a newer vaccine, but really important for pregnant people to be up to date on their COVID-19 vaccine. So it does protect from serious complications for the pregnant person. And COVID-19 during pregnancy is shown to increase the risk for preterm birth or stillbirth. And it's safe to be given anytime during pregnancy. And right now, it's just, that part of that normal schedule for adults. So ensuring that, they have at least that one dose of the bivalent vaccine. But as we know, the schedule continues to evolve. So that's where we're at right now. The link right there is the vaccines during pregnancy handout that I mentioned. Another vaccine that it talks about is hepatitis B vaccine, but I kind of talk about that a little bit later. So it also goes into this handout whether or not a vaccine, shouldn't be given during pregnancy, which is, MMR, varicella, HPV, and, whether or not the vaccines can be. So really, really helpful if you are a provider that provides vaccines to pregnant people or, recommends them. So next slide, please. And I mentioned that vaccines, when you are pregnant, you are at higher risk for complications. And part of that reason is because your immune system is suppressed during pregnancy. So, you have a harder time fighting off disease. So having that immunity, from vaccines is a safe way to, protect yourself from disease. And then later in pregnancy, due to that increased fluid volume, which can make, the respiratory illnesses like flu and COVID, much, much harder on you. I also think about community immunity and the importance of staying back vaccinated to protect those around us. So, I think that is an important piece in talking to everybody about vaccines, especially, flu, COVID, MMR, and just thinking about like these vaccines that are given, kind of in early childhood, such as our MMR vaccine, and I'll talk about it on the next slide, and varicella, that, these diseases can cause real, complications in people who are pregnant. And so, maintaining that community immunity, as a whole is important to kind of, we think of, cocooning the baby with, pertussis protection. We can kind of cocoon our community and make sure that there aren't, outbreaks of these diseases, or these diseases aren't, spreading, rapidly in our communities. So I think that's another piece to think about as well. Next slide, please. So I mentioned the childhood vaccines offer protection. Obviously, there's more vaccines than just these two, but these are the two that I really think of when I think of protecting people who are pregnant. So MMR, measles, mumps, and rubella, and varicella or chickenpox. Both of these are live virus vaccines, so they aren't given during pregnancy. And rubella disease, we don't hear about it very often, but if a person gets it while they're pregnant, it can cause miscarriage, stillbirth, and birth defects. And our varicella or chickenpox virus is also not given during pregnancy. And if a pregnant person gets the disease before 20 weeks, it can also cause birth defects. So, I think it's, important to get them, during childhood for a variety of reasons, but even, thinking down the line, during pregnancy, you already, you want to be immune to these illnesses prior to getting pregnant, as well as you don't want to be, spreading them and potentially putting others at risk. So next slide, please. And then thinking about talking to people during pregnancy about vaccines. So there's, of course, protecting, yourself as you're pregnant, protecting your newborn when they're born. And then also part of that conversation is talking about vaccines, for their child in the future. I think it's a lot of people, make decisions around whether or not they're going to vaccinate their kids, during pregnancy, or when they're thinking about becoming pregnant. There is, the birth dose of Hep B, so they're already, kind of talking about that with their provider, making their birth plan, and then, that is helping kind of form their opinion and their thoughts on, are they going to get vaccinated at 2 months and 4 months and 6 months and so on and so forth. So I think it is really important to share accurate information and reliable sources on vaccines. And not all of those, it doesn't have to be, the CDC. There's a lot of really great information from nonprofit organizations, from different, from public health, of course, from CDC. There's a lot of really great materials, and just, sharing with people how to find accurate information, because as we know, there's a lot of misinformation and disinformation on vaccines out there. And it's, a time that, you're thinking about a lot, or you're thinking about a lot of different things, and you're thinking about the safety of your newborn, and that's the top priority. And so just making sure that folks do have that good information, so that they can make the safest choice for their family. And in the vaccine world, kind of across the lifespan, we know that a strong recommendation from a healthcare provider is one of the most, important factors in whether someone is going to say yes to getting a vaccine that day. So, even, sharing, answering folks' questions, like, is important, asking, specifically, what information that they're looking for, and, being able to provide that information. is important, and then stating that you strongly recommend that you get the TNAP today, or that get Hep B birth dose, or get your childhood vaccines, or later vaccines. So that is very important piece for folks. Folks really trust their healthcare providers, and for good reason, watching out for their health. So next slide, please. All right, and then I did mention just a little bit about the birth dose of hepatitis B. It is recommended for all infants, and ideally within 24 hours of birth, for birthing people who have hepatitis B. That is, I believe, within 12 hours. And I do include the link to the perinatal hepatitis B treatment or guidelines for the baby. So, and there is that universal recommendation for hepatitis B for everybody. It's I think, I forget how long ago it used to be a risk-based vaccine, but we know that hepatitis B can spread easily. It can spread through childbirth, it can spread through cuts, sores, sharing toothbrushes, chewed food, etc. So it really is a universal vaccine recommendation. Next slide, please. And then I just wanted to touch on RSV vaccines. I don't know if folks have been seeing the headlines, but the FDA is analyzing 2 RSV vaccines, and they did approve the one for older adults. So there's a lot of excitement in the vaccine world around that. And they're also looking at the RSV vaccine for people who are pregnant. So thinking about protecting the newborn when they're born, again, with the passive immunity of giving the vaccine during pregnancy to protect the baby once they're born. As we know, RSV, although it can, be like a simple cold for, a healthy adult, it can be very scary and harmful for a newborn infant. So the FDA did review the Pfizer vaccine for use during pregnancy at their May meeting. And there was a unanimous agreement on, that this vaccine works. So 81.8% protection through 3 months, and 69.4% through 6 months. So really great information, really great data on the efficacy. So there was a lot of questions and discussion. There was a split on the safety piece. So they did see a slight increase in premature births over the placebo. It was not a large increase, but there is concern. There's obvious concern about that, and kind of even more concern because a different vaccine brand GSK stopped their late stage clinical trial during pregnancy to analyze safety data on premature birth and associated neonatal death. So, they want more, data and more information on that piece, of course, before, recommending. And, I think that, this, we're kind of more used to seeing kind of the process of how, vaccines are approved, with kind of the process of COVID vaccine, being very public. So it is, kind of interesting to watch how, this vaccine, will progress that system, and, how they'll get the data that they need, because vaccines are held to a very high safety standard, given that they are, often given to, healthy people to protect, we don't, of course, want to cause harm. And I think also, probably weighing on the FDA panel's mind is the RSV vaccine from a long time ago, decades ago, had some safety issues as well, which is why, it was pulled. And, it's been, like I said, decades of progress and of science, like leading us to this point. So, we'll they're due for an approval decision in August, per the news reports. And, you know, we'll see what they decide and what the data shows. So more on that. I, you know, from my standpoint, you know, continue to watch that, you know, so that I can, you know, be informed and provide that information to providers in our community. Next slide, please. And that is it for me. Does anyone have any questions? On the next slide, there are some resources about the RSV vaccine for some light reading for folks, if you are interested.
Thank you so much, Kate, for some great information and updates. And a reminder to everyone that we will be posting all of these slides on our website. And we do have that new website on the Tacoma Pierce County Health Department server that will be up at the end of our meeting today. Kate, I was curious though, if any of these resources or perhaps the link to that handout on vaccines and pregnancy, if you wouldn't mind dropping those in the chat for people to be able to access easily today, that'd be really great. And
yes, sorry, dealing with multiple screens. I can definitely drop that in the chat.
No worries. Thank you so much. And I'm not seeing any questions coming through in the chat, but I'll just open this back up for a moment to see if anybody has would like to unmute and have any thoughts or questions. Well, all right. Thanks for posting that in the chat, Kate. And we appreciate your time today. Always awesome to have you.
Thanks for having me. And my contact, I can drop my email in the chat too. If folks think of questions later or just didn't feel like asking them right now.
Oh, that'd be great. Thank you. Okay, so I'm going to move us forward and back into the PCPC committee updates. So I appreciate Robin having already presented on our CRIBS committee. And I will be doing a quick update on the Pierce County Breastfeeding Alliance in lieu of Patricia Alva, who unfortunately is not able to join us today. But for those of you that are not familiar with the Pierce County Breastfeeding Alliance, that group promotes and protects breastfeeding through education, outreach, and collaboration here in Pierce County, and also partnering with that Breastfeeding Coalition of Washington State. They did resume their meetings after a temporary hiatus back in, I believe, February. And so those meetings are occurring. And if you would like to get involved in that alliance, please reach out to Patricia, have her contact information up here. I'm actually really quickly. I'm also going to drop all of these folks' emails in the chat once we're done with our presentation. I'm not able to do that right now while I'm managing all of these screens. And Robin Wybie is our contact for our First Steps, the MSS and ICM committee. She also is not able to be here today. That is correct, right? Robin, you're not here? No, I don't think so. Okay. So the First Steps Committee's focus is to engage with all families, to ensure that the MSS program is engaging with all families eligible for the First Steps services, which includes maternity support services and infant case management. The committee helps provide direct referral resources for families in that perinatal and postpartum period, and they partner with other programs that provide and support those services. And they also, during their meetings, provide education on the importance of First Steps and its critical work, and they do that outreach with different agencies around the community as well. There are quite a few organizations that are participating in this committee already. We've got health representation from Healthcare Authority, Answers, our Black Infant Health Program, maternal child outreach program team, pardon me, there's Family Partnership, all here at Tacoma Pierce County Health Department. We have Hope Sparks, Family Connects, Step by Step, and Community Healthcare are all currently involved. If you would like to learn more about when meetings are held or get your organization involved yourself, please reach out to Robin. All right, and we also have our Perinatal Emotional Health Committee, and that is led by Muriel Herrera Velasquez and Taylor Kerrigan. Neither of which were able to be with us today. But if you're not familiar with this committee, their goal is to reduce their barriers to care, to behavioral health care, increase screening and referrals, increase the number of trained providers available in Pierce County to provide services during the perinatal period, to increase community awareness about PNADs and Pierce County resources available to support families. They advocate for system changes as needed and maintain resource and referral guide for pregnant and postpartum families in Pierce County. And they do a really great job of keeping that up to date. They also host the perinatal mental health support groups. And if you are interested in more information on joining this committee, or you would like more information on getting access to this referral guide or the support groups, please reach out to Muriel and have her contact information in the bottom, which I will also drop into the chat when we're finished. And last but not least, our PCPC Education Committee is back up and running. We took a break over COVID-19 response because this committee was focused on providing learning opportunities in the form of an annual all-day training, as well as lunch and learn meetings. And through the pandemic, we were taking a break from hosting any kind of in-person meetings, but we are back in business and we are anticipating our first education day in a few years coming up this October. We're planning on a half-day in-person event. More information will be to come. We're still finalizing a few details on that, but we'll make sure that we send out those details to our general distribution list so that all PCPC members will receive that invite as soon as we have those details nailed down. And please feel free to reach out to me if you have any interest in joining that committee or just have any additional quick questions about what we've got planned for October. And just a reminder to everyone, our new website on the Tacoma Pierce County Health Department server is up and running. Our old website, pcfpc.org, has not been taken down or removed yet, so that is still in existence. We're still finishing up the transfer of all of the information. However, you can find our new website here. When you get the slide deck, I have the link here, but you can also just write down this website and I'll throw that in the chat here as well. And our next meeting is going to be on September 11th. You will be getting a survey coming out to your email here within the week. Really appreciate everybody's feedback about the meeting today. We are wrapping up a few minutes early right now, so I'd like to pause and just open up the floor for maybe anybody has any updates that they would like to share about their organization, any feedback, comments about our presentations today. No? Okay, well, I just want to thank everybody for being here. Oh, Erin. Oh, I thought someone was going to unmute themselves, but doesn't look like it. Thank you so much for everybody being here today. I'm going to be leaving the meeting open for a few minutes while I post some of these contact emails in the chat. Everybody who's here, please feel free to, if you want to use this extra few minutes to come off cam or on camera and do a little chatting or networking, catching up. I just welcome you to make use of this space for that. But for those of you that do need to pop out, just thank you for your time.